So it's a real pleasure to be here, and I'm only sorry that I can't be here for more of the day. Unfortunately, I'm clinical today, but delighted to come and have a chat about some of the work that we have been doing in the safety team on PIC. I don't think this graphic will be a surprise to most of you. It tries to show event probability on an everyday basis, what we do in our normal daily work. And traditionally, our safety focus has been at this end. So the healthcare-associated infections, the morbidity reviews, drug errors, never events. And we've put huge amounts of effort, and rightly so, into trying to learn from those episodes and make changes that can make our care safer. At the other end of the scale, we've got what I like to call moments of magic, the things that just make you think, oh my goodness, how did that happen? I want to be like that. I want to do something that has that kind of impact. And I had one of those on Monday night when I was on call, when I was expecting a child back from cardiac theatre whom I knew had had incredibly long, incredibly complex surgery, and I thought she was going to come back maybe on ECMO, certainly chest open and really, really sick. And essentially she was wheeled through the doors of the unit at 10 o'clock at night on minimal doses of adrenaline, looking incredible, and was extubated the following day and left PICU 48 hours later. And I was thinking of how could you replicate what happened in the 12 hours that she was in theatre, that absolute excellence there, and learn from it. There is so much to look at and learn. So the exceptional performance is invaluable, but that is also at this other end of the scale. And what I've been thinking about, and we in the safety team have tried to address over the last 2 to 3 years, is what about this middle bit? 96% of our work that generally goes unnoticed because nothing happens. It's not exciting. Things get done, objectives get achieved, but it's the vast majority of what we do. So why is it working? What are we doing? Every day we make effortless readjustments, and some more effortful readjustments, those workarounds. And some of the time, those workarounds are really good. And actually, we should be making that the routine. It shouldn't have to be somebody thinking, you know what, it would work better if I did this. Some of the time, they mask an inherent problem that we need to address before harm arises as a result of it. So there are huge amounts that we don't know. And safety too is about looking at your system's ability to function as required under every range of circumstances. Are we resilient? And it very much is work as done, not work as imagined. And I read this quote a couple of days ago from Eric Holnagel and just laughed out loud that gap between practice and theory is much larger in practice than it is in theory. And that made perfect sense to me. I don't know what my registrars do on the shop floor because I don't have to do their job. So I shouldn't be trying to change what they do without asking them what they think will work. What would make life easier? How could this work more seamlessly? When we started thinking about this, as I say, 2 to 3 years ago in our safety team, we decided that it would be a good idea to do a pilot project. And the question was really, could we learn more from that proactive patient review of their entire patient journey than by what we were currently doing? So very much following on from the Vincent Health Foundation report of anticipating monitoring. And we decided to look at children having cardiac surgery. And initially it was just going to be on PICU, and then we thought, well, that doesn't make sense. That's only a tiny part of their journey. Let's do it from admission through to discharge. And we just didn't know, A, whether we could learn from doing that, and B, how should we do it? Should we do it looking for things that could go wrong, that were hazards, that were quality gaps, or should we do it looking for things that were going well? In the event, we did it in 2 separate phases. And the reason for that was very simple. We started off trying to do everything together, and we learnt that we were very, very good at picking up the things that could go wrong and the safety quality gaps, but we were missing huge amounts that was going well because we were so focused on looking for the negative. So that first phase, we just concentrated over a 2-week period of looking at these children for hazards or safety quality gaps. And in total, 5 children, we identified 197 issues. We initially categorised them using the Systems Engineering Initiative for Patient Safety. And that groups events into 5 categories: person, organisation, tasks, tools and technologies, and the environment. And no one working in healthcare will be surprised that the commonest groups were person and organisation, particularly inter-team communication, lack of standardisation, a constant sense of really pushing capacity beyond that which was felt to be safe, and transfer and discharge planning being an area where our parents felt very vulnerable. We then looked a bit more closely at the actual hazards. There were just under 100 of these, and when we broke that down to a hazard per patient score by care area, again, no particular surprise that the riskiest place was cardiac theatre. But look at this. This is a theatre to PIC transfer, so less than 15 minutes in duration as compared to several hours in theatre, several days in PICU or the ward, but a hazard per patient score ratio of 3.5, so high and one of the riskiest areas. So we felt that in that first phase of our study, we'd learnt lots of low-lying fruit that we could change, the standardisation, the discharge planning, but much harder concepts in terms of inter-team communication and understanding each other. It was very much separate silos who didn't know what each other was doing. We then went back and did exactly the same thing, but we closed our eyes to everything that we thought was wrong or could be better, and we looked at what was working, why it was working. And it was very much more qualitative than quantitative data. We couldn't categorise it in a nice SIPES framework. But what we saw were all of these workarounds that really were maximising surgical throughput and efficiency. And we'd been quite concerned about that at the other end of the spectrum, thinking, oh my goodness, all of these children that are listed and then cancelled. Actually, that maximised surgical throughput and efficiency, so perhaps more an efficiency quality in terms of the impact on the family experience trade-off rather than an efficiency thoroughness trade-off. We'd worried about inter-team communication and understanding each other. If you went and observed communication in cardiac theatre, it was like a masterclass. So effortlessly, closed loop, flat hierarchy, situational awareness, contingency planning. How do you then translate that in a very small, cohesive team who've worked together for many years to a PICU with a total staff of over 350? Tough, but that doesn't mean that we shouldn't try and we shouldn't encourage that teamwork and communication. So what did we learn from all of that? It is very much all about the people. We are our own greatest strength. We have our limitations, but generally the flexibility, the adaptivity and the communication skills that we have and that we can develop further are what keep us safe. We think that we learnt huge amounts for this study, but it was very resource intensive. So how do we look at safety 2 on a day-by-day basis? And when we've been thinking about that again, we know that we think we're looking at the safety 1 work fairly effectively. We've got learning from excellence, which is incredible. What are we doing about this bit in the middle? And that's hard, and I don't have any easy answers, because if you say, should I be spending hours on this where nothing is happening, or concentrating my time on things where there is a real risk, that's a difficult argument to have. We are continuing to look at patient journeys, albeit just on PICU. We are using debriefs and trying to feed back the learning from that. And we very much want feedback from the staff, from the staff forum, and also from our parents and their families. And it's about that work as done, not work as imagined. Ultimately, it is all about looking after each other. You can't keep your patients safe if your team isn't safe. It is working as a team with that patient and family involvement and feedback. So if you ask me what I think about safety 2, increasingly over the last few months, I'm starting to dislike the concept of safety 1, safety 2. I actually think it's a spectrum and we should be looking at all of it, and missing out the intelligence in that middle bit doesn't make any sense to me. The other thing that I've had to recognise is that as healthcare professionals, we like our p-values, we like our proof, we like our science. Just because something isn't concrete doesn't mean that it doesn't hold huge amounts of information that we can learn from. And that's what we are trying to do in an iterative, ongoing process at BCH. Thank you.